I think in this case, some people will still be streaming in, but I think now we can just get started. I want to start by just giving the participants an opportunity to introduce themselves and share a little bit about their journey and where they are along their path to being family practitioners.
Who do you want to start?
I'm happy to
We
start.
can do whatever. Yeah, go ahead.
Sweet. Hey guys. So let me know at any point if you can't hear me. The sound here is a little bit strange. But my name is Saloni. I'm in the Cleveland Clinic Learner Program. I, like the rest of us, will be graduating this year. I'll actually be going off to University of North Carolina for family medicine, obviously. And then some of my interests in family medicine include like OB health, LGBTQ plus health, and like reproductive health care.
Thank you for that.
I can go next. My name's Olivia. I am headed to Boone, North Carolina, also North Carolina. And it's part of the Mountain Area Health Education Campus programs. They have several: Hendersonville, Asheville, and Boone. So I will be learning full scope rural family medicine in an unopposed setting, which means that we're the only residents in the hospital. I am really stoked. It's been quite a journey to get here, but I'm really looking forward to it. We do it all. We deliver babies, we do addiction medicine, we do lots of psych, and lots of procedures.
Hi, my name is Christian. I'm in the UP program, also graduating this year, and I will be starting my FM residency program in Anchorage, Alaska, and it at Providence Medical Center. And then my interest is mostly rural, full spectrum family medicine, and which kind of fits perfectly for me in Anchorage, Alaska, because their program is mostly like rural frontier medicine.
Right. And thank you all for coming in. Thank you for sharing your story. I think that we have a really good representation of so many of the aspects of breadth that I personally loved about FM. So in order to start, you all talked a little bit about the practice you envisioned after training, but the questions I want to ask, we got a lot of questions that kind of fit into three categories. So we have some that are about the experience in medical school, some that are about applying for residency, and some that are about plans for the future. So I wanted to start off with kind of a big question, and panelists can feel free to jump in as they please, but I feel like we get a lot of one-size-fits-all advice about how to apply to residency, things like doing research, honoring rotations, succeeding on step 2. And I wanted to ask what aspects of that advice were particularly applicable or helpful in the journey to FM? Maybe if any of it was less helpful for receiving an FM match than it may have been in other specialties.
Probably for me, it was the research component. I know that at Case, we emphasize a lot the research component, and I think it's because a lot of our students end up going into fields where research is highly expected of you. I still think that because it was a significant part of my application, it still came up fairly often in my interviews. And so I wouldn't say that it really went to waste. It just became part of what I was bringing to the table and what I was talking about during my interviews. So I would say that, whether you end up doing a lot of research or not, it's all about how you package it into who you are and what you want to bring into your training program.
I'll share that I think the most helpful advice that I got was reaching out to others when I was taking STEP. STEP is not the end all be all for family medicine, but it is important. Like, you don't want your application to be screened out because you did poorly on STEP. I think that the biggest place of support and resources that I got was the connections through other organizations like the American Academy of Family Physicians, with whom I've served for the past 2 years, the OAFP, the Ohio Academy. And I'm a member on the board right now, but I've been serving with them for almost all of medical school. those resources were huge, as well as the Rural Medical Training Collaborative. I'm actually like rocking my shirt right now from we just redesigned the logo. But they're all about all the rural FM programs. So I think that like having a variety of resources and places and people to reach out to whenever I had questions, because family medicine is so broad. And when you're looking for a residency, the questions can get pretty specific and nitty gritty. And also there were questions that I didn't realize that I wanted to have answered. And being able to reach out to my friends who were at different stages of their training or had just gone through the match, that was really helpful.
Yeah, thank you for that. And to jump off the point that we were talking about, Christian, you mentioned talking about like packaging everything into a coherent application. So a question for all the panelists would just be, during your medical school journey, did you come in knowing that you were interested in the types of practice that now appeal to you in your future training? Did you discover that? How did you discover that? And how did you start building a narrative around your application?
So I'll say that up until probably the application year, I was still undecided. So, and that's because I was interested in both like medicine, but also procedures. And so I actually did 2 AIs, one in family medicine and another one in general surgery, because I knew that I was interested in rural care. And as a rural general surgeon, you could still do a lot of primary care. So I was really undecided between those 2. And at the end of doing both of them, I just felt like I clicked better with the FM folks instead of the general surgery folks. And that's how I went down that sort of that pathway. But I knew pretty early on that what I wanted to do was primary care, and that it entails some type of full scope practice. And that came up often in my interviews, because your program directors will see your transcript and will see that you did, in my case, that I did an AI in surgery and then one in FM. And, people would be like, so how is this? How did you come about doing both of these? And so it's really being very self-reflective about that, and then bringing that honesty about your own sort of your own journey to the table when you're interviewing with programs. And I think that programs appreciated that level of honesty and authenticity.
I will say that, thankfully, I love that you just said those words, honesty and authenticity. Those 2 things I think are really important values to family medicine. I will share briefly that I didn't match. I soaked. And I want to be really transparent about the fact that I was kind of riding a high. I just had a beautiful dinner out at Cordelia with a Michelin-starred chef who was guest cooking at Cordelia last night to celebrate the fact that I did soap successfully to a wonderful program. But we talked about the fact that, I was really riding high. Like, I'm a Pisacano scholar. I've served nationally with so many organizations. I don't have red flags in my application, and I did not expect to be somebody who wound up in the soap. And so I want to share this because I think it's really important to share this part of my story, because it was really painful and very unexpected. And I doubted whether or not I was a good applicant. And I just want to share this so that folks know you can be magnificent and wonderful in every way. And the match might not work. I'm not an algorithm girl. I've never been an algorithm girl. I wasn't an Anki girl during school. I don't follow the rules. People know this. And not every program is ready for that. And so I found a program that's ready for me, because I'm not a yes, ma'am, no, sir, keep my head down, smile and nod, do the status quo type of person. And so it was really important to me to find a place where I'm not going to bonk heads with people. And, unfortunately, I think that I should have been a lot more transparent about that and really explicit in asking programs about the culture of their program. Because I think that the places that I ranked recognized that I wasn't a good match, that they weren't a good match for them. Not that I wasn't a good match for them, but that they were not the right environment for me as a leader and as a thinker and creator and doer. And so it's really important to, you know, close your eyes and be true to yourself, right? Don't think about like, what does everybody else want me to do, or what is the most desirable place to be, but what fits you. And recognize that you are powerful, right? We are going to have a shortage of 125,000 physicians in 2030. Most of those are primary care physicians. And so like, you're powerful in that, and like, be selective. I'm also here for anybody who goes through SOAP, whoever listens to this now and then like has a panic attack next year. If that is you, God bless you. I'm here for you, and I will talk you through it. I forget what the question was, Joey, but this is me rambling.
Oh, no, thank you for sharing. We were just talking about how we learned what our interests in medicine and the types of practice we envisioned were actually good fits for us. What we did in medical school to start forming the narrative around our application and making it authentic.
I think just to add to that, I think Olivia was so on point with the fact of like I think being in family medicine, you do have the like ability to be a little bit more selective because they want you for the most part, right? A lot of places want you. You have a lot to offer them. And family medicine is so diverse in terms of like what interests different programs have, what curriculums different programs have. So finding something that fits you is really, really important. And I think for me, like a big thing was seeing mentors and like seeing what practices are possible, because I think in our medical school curriculum, I don't know about the UP side, but on the learner side, we barely get any family medicine exposure. And the little that we do is kind of like the bread and butter, like diabetes, high blood pressure, which is great, but you don't get to see the like delivering babies piece. You don't get to see the like procedural aspect of it. And so like knowing that was a possibility and knowing what that looks like in future practice through just like talking to mentors and talking to other family medicine preceptors that I work with was really important for me. And then also knowing like going through third year, when you go through like the different rotations, knowing which ones call to you. Like for me, I really liked OB, but I also really liked internal medicine, and I was trying to figure out what field could do both, and family medicine is kind of where I landed with that. So kind of talking to people and seeing like what is realistic, what is valuable. I think a lot of like the interest groups, like they have people from like direct primary care come and talk, so you get a feel for like what the diversity of careers looks like outside of academic medicine, because I feel like we just don't get that exposure here.
Yeah, thank you for that. Thank you for that, Saloni. I think that brings up a
Joey?
really good point. Oh, yes, please, Olivia, go ahead.
Sorry, could I just piggyback off of that? I feel like this information is potentially pretty useful for folks who are going to listen to this. If you don't already know where like family medicine is really thriving in Cleveland, Metro is definitely a place where it is. There are physicians there who still have OB privileges, who run the jail clinic, who are doing a lot of like underserved outreach and care, and they have a lot of autonomy to have a full scope of practice. Unfortunately, that's just not true at the other two healthcare systems that are in Cleveland. And so I strongly encourage folks who, you know, I was just at a meeting where we were discussing the American Board of Family Medicine results, which this is like low-key a secret because it hasn't been published yet, but it's like not a big deal. I'm allowed to talk about it. But we find that most folks, a significant portion of medical students are choosing family medicine actually in the fourth year. After their clerkships are done, but before their rank list is due and, you know, the match happens. And so what used to happen is that the vast majority of family medicine residents, they were people that we just had to keep in the fold. They knew what they wanted to do when they got to medical school. That is no longer true. At this point now, family medicine has to kind of capture students and keep them. And so I would strongly encourage people who are considering family medicine, whether it's as a backup or because you think that you might really be interested, make sure that you give yourself an experience that is giving you the full exposure to what family medicine actually is. I'm notorious for being on calls with people where I don't lie to them about why students don't want to go into family medicine. Because if you have a family medicine experience where you see a bunch of people doling out prescriptions and managing chronic disease and staring into a computer and not getting to engage with patients, taking their time and being thoughtful and having that beautiful longitudinal relationship that is unrushed and relational, then yeah, I would look at that and be like, ew, why would I want to do that? So please give yourself the opportunity to really cultivate an experience that is going to give you an accurate picture of what family medicine could look like. I'm not saying that family medicine doesn't look like chronic disease management in chaotic adult outpatient clinics in Cleveland, because it does, and it does look like that in other cities too, but that is certainly not all it has to offer. And you are, again, like, you're in control, you have the power, other people depend on you. You get to decide what your practice is going to look like. And if we all stand up together and say, like, actually, as a family doctor, like, I'm trained to deliver babies and do all this, we are going to be able to do those things. So I just wanted to like emphasize that. And if you need help finding folks to shadow or experiences to create, please feel free to reach out to me, reach out to Joey. There's so many family doctors in Ohio who want to see you succeed and help get you the experience that you want.
Yeah, thank you for that. I think that leads really naturally to another question that we had. So in addition to prioritizing an experience at Metro, if possible, when directly examining FM, what can what can third year medical students or fourth year medical students do to get the most out of their rotations? Are there ways that you can use other rotations to get experience in key areas? Are there ways to make sure that you're going to the right places or building the right skills?
I would say absolutely, because family medicine is nothing if not an amalgamation of all the other medicines. So I like family medicine inpatient is basically internal medicine inpatient. In terms of skill level, in terms of like the things that you're going to see. OB, maybe not C-section if that's not the route you're going, but even if you do want to do a C-section fellowship later on, all of those skills, how to manage prenatal care, how to manage pregnant patients, how to manage delivering patients even, are all very, very applicable. Everything in peds, very much applicable. So I would say pretty much every single rotation you do, I can't really think of one where you wouldn't have anything that wasn't somewhat building your clinical skill set, whether that is just reasoning skills, whether that is diagnosis skills, treatment skills. I think all of them are valid. I think all of them have helped me, at least to some degree, just building kind of like comfortability with different populations, comfortability, managing certain aspects of it. And you get really good at like, at least for me, I think the reason that I went into family and the reason that like still drives me is every time I was discharging a patient, my concern was, how is this patient going to follow up outside? And so when you think about it like that and you write your discharge summary for the outpatient person, I think you're already starting to build those skills that are going to be so useful to you as a family medicine doctor.
This is me sending virtual like cheers for that comment about like what happens to this patient after they leave. I'm hopeful that most of the folks listening to this are going to be like third years who have just finished clerkships and notice like that big gap, right? Family doctors are the glue that kind of hold that whole piece together. This healthcare system would be so broken without us because we are that continuity. I'm so glad you said that, Saloni. That was beautiful.
And I would also add, try to make the most of every rotation and elective, even during your fourth year, and try to connect it somehow to what role you want to act in a community as a family practitioner. And I'll give you an example. So I did a 2-week elective on pathology, and I chose to do it because I was going to be in the lab those 2 weeks. But a lot of times patients share a lot of anxieties, a lot of uncertainty regarding biopsies, regarding diagnoses with their family doctors. A lot of what goes on in the background, a lot of times just doesn't get discussed with patients. And so my perspective coming into that elective, and I would openly share it with pathologists, was as a family medicine doctor, I want to learn more about what goes on behind the scenes so that when I have patients with questions and anxieties, I can provide the kind of questions that can, bridge their questions by the time that they get to speak to someone like a pathologist about a cancer diagnosis or, some kind of malignancy. So that's one way of finding that purpose in electives, and that'll be really well received by different specialties when you're coming in with a clear purpose for why you're there, not, I'm here because this is just another box to check.
Yeah, thank you for that. So just being very very explicit about these are the skills that I can gain that would be relevant for the practice that I envision, and being sure to emphasize those and advocate for yourself on the floors, on the wards, or in the lab to make sure that you're given those experiences. Yeah. That also leads us to another question, which is trying to find a residency program that's going to align with your interests. And one of the things that I think makes FM unique has been discussed is just the total broad spectrum of experiences you can get, from being more in the outpatient setting to being unopposed and having pretty much complete access to so many different parts of what goes on in the hospital. I wanted to ask more about what kind of things can you look for to figure out what kind of training opportunities a program has, and what kind of cultural elements a program has to make sure it's a good fit for both the doctor you want to become and the person you intend to become.
I think one big thing is to see what precedent the program has set for the scope of practice that they're training residents in, and talk to the residents. So one of the opportunities I already talked about, like AAFP National Conference, which is like the biggest conference of its kind, created explicitly for students and residents, but particularly for medical students who are looking at residencies. Their residency fair is incredible. You can talk to the residents who are training there right now and be like, what is your day-to-day like? What's your relationship with OB like? Can you give me an example of the last time that your residency created a new pathway for someone to learn something that wasn't explicitly offered in your curriculum? Examples that I've learned about that were really green flags for me when I was looking for programs was an example specifically in the University of Colorado health system, where they have a really strong rural pathway program where they send students to the University of Denver whenever they need more specialty type training or more volume. And so this program had created a longitudinal opportunity for someone who really wanted to be able to scope, to go and do scopes for like 3 days of every single month of their second and third year in Denver. And to me, that demonstrates that that program's priority is education, right? Not trying to use you for labor, and making sure that like this is a priority to you because you want to go serve in a rural community, right? And so they're making sure they're not saying, oh, well, yeah, we'll give you 2 weeks to go scope as many people as you can, because that's not how you develop competency, right? It's important to have that longitudinally over time. And so thinking about like, what kind of skills do I want to come out with, and how am I going to defend those skills, you know, to whoever I want to be employed by, whether it's working in an emergency department or being a hospitalist. And by the way, one other thing to just keep in mind for folks who are listening, who are maybe on the fence about like family medicine or med peds or something, or maybe you want to do peds. Pediatricians now have to complete a 3-year fellowship on top of their residency, even if they're trained in residency almost exclusively in a hospital-based setting. Family doctors do not have to do that. We will never have to do that because we have such strong advocacy at so many levels of government. And it is honestly absurd to me that pediatricians have to do that, because they now have to do 6 years of training to be able to take care of children in hospitals. They should not have to do that. And they're taking a pay cut to do it. And pediatrics matched horribly this year. And I think that that is a huge reason. So knowing that like you're potentially entering a specialty that has your back, and there's a huge network of folks who are willing to help advocate for you, whether it's your state chapter or the national chapter, to help demonstrate and advocate for you that like you are competent to do these things that are in your interests. But I think definitely make sure, find a resident or find a person who kind of embodies the type of practice that you want to have in the future, and know what their graduates have gone on to do.
Yeah, just to piggyback off that, like absolutely see what people are actually doing, because I think I've had a lot of programs tell me, oh yeah, like we do good OB training, but then nobody actually does OB out afterwards. And so to me, that's like a little bit of an orange flag of like, I'm sure you get the training, but nobody either wants to do it or feels really comfortable doing it afterwards. So you want to look at that. I think in terms of like interest, I had at least like 3 kind of big categories of like deal breakers, like my program has to have this, like would be nice. And then like extra stuff. So like for me, the deal breakers were like, I need to have access to some degree of reproductive health training. And I know North Carolina, maybe not like the hot spot for that, but like my program specifically has people who have been able to get it in elective form and like have gone on to do work with it. OB training, like really strong OB training with people robustly going out into the communities and doing OB afterwards. And then LGBTQ plus training. So again, some sort of either clinic where you can do an elective, or whether it be built right into like your longitudinal continuity clinic, something like that. In terms of like nice to have, or like something that I like want to do, but it's not a deal breaker. Underserved care in general is like big for me. So I'm specifically doing like the FQHC program at UNC, which is working in a rural health clinic for my continuity clinic. And then kind of along with that, I really wanted to be able to learn Spanish and speak Spanish to my patients. And that facilitates that, even though it's not necessarily built into the program itself. So I think like when you're finding interests, figure out what is absolutely something you need to have. What skill set do you need to have? Is it delivering babies? Is it certain types of procedures? Is it behavioral health? And then use that to kind of narrow your list down. And then you can kind of put them in tiers depending on what has like the most amount of stuff that fits your career and your needs, and then like kind of going down from there.
And I would just add, in terms of, Joey, what you were asking about culture, that you can also kind of notice from an interview what the program likes to market a lot and what they sort of don't like to talk a lot about. And then that's an opportunity for you to ask more about that, because if somebody's not talking too much about that, then that's probably something you do want to be asking about. So for example, there were schools I interviewed at that would spend easily, the residents or the program director would spend easily 15 minutes talking about sports medicine. So that told me it was a big sports medicine program. It was very robust. And then, maybe just a couple minutes, 5 minutes on OB, which that prompted me to ask, again, very, very specific and direct questions of saying how hard or how easy it is to get 80 deliveries by graduation, which is the amount required for you to practice independently as an FMOB doctor. And that's when residents would either give me the green flag or red flag. And examples of those would be, you're part of the team, we feel like you belong here. And there was a case where a resident told me that this person was walking into the hospital and the OB attending saw them in the hallway and said, "Put your scrubs on, we have a delivery that's about to happen in a couple minutes." And so even the OB faculty always had the FM doctors in consideration, that they were part of the team, versus other programs where perhaps residents would say things like, "You'll have to advocate for yourself," or you'll have to hover around, you'll have to show your interest in order to gain some trust from the midwives or from the OB attending. So it's sort of telling me that I'm coming more as an outsider, and I need to gain that trust from the team, which says something about how the team sees FM in the care of OB. So there's different, those different systems will have different cultures about how they see the role of an FM doctor in the care of OB patients. And in regards to the other stuff that you were talking about, similarly to how Olivia said and Saloni said, I typically just broke it down into categories, knowing that not everything fits in perfectly, right? But did I want to be in an urban area? Did I want to be in a rural area? Did I want to practice or train in a program that was predominantly ambulatory training, or had a strong first year of mostly inpatient, which looks a little bit more like an internal medicine program? So those were all questions that I took into consideration, even when I was ranking my programs.
Yeah, thank you everyone for that. A quick follow-up question to that before we dive into some other topics is, what are the best ways to meet residents from a program? Should we be cold calling, cold emailing? Should we be counting on conferences and interview days? What are the best ways to get that information?
Go to AAFP National Conference, and also keep an eye out on newsletters and in organizations for opportunities to meet residents. They often will do a virtual meet and greet. I know that the Colorado programs, especially the rural ones, have had a meet and greet. I think that they do this every year, but they definitely had one a couple of years ago. I ended up getting connected to a resident because I screwed up like the time zones, and so I missed it. But the coordinator for one of the programs was so sweet. She was like, "What are some of your interests? Let me match you with somebody." I got to talk to the resident who was incredible, had this really strong interest in OB, really strong interest in integrative medicine. Her grandmother had been a traditional healer in her community. She's like from the Caribbean. And so that was just so cool. We like connected about all these things. We stayed in touch. And then I actually met her in person when I went out to Denver and she was on a rotation there and I was visiting a friend. She was a wonderful like touch point for me to have on my journey. And I think that the more that you just advocate for yourself, figure out what you're looking for, and know what you're interested in, even if it's everything, like be able to say, like, these two things sound really cool to me. Is anybody in your program doing that? And then just chat with people. The more that you can get to know people, I think, as like friends too, and have something in common with them, the easier it's going to be to ask the, tougher questions that you really want to get answered before you choose a residency.
And I would say identify case grads that are in programs that you're interested in, because the likelihood of them responding back to your email out of nowhere is much higher than just replying to somebody who you probably have no connections to.
Yeah, thank you for that. Next question I want to talk about, something that we've addressed peripherally. We had somebody who wanted to learn more about what kinds of things you talked about in your interviews, and maybe if it was the same across most programs or if there's a lot of variance in the topics of discussion.
For me, my experience was that there was a lot of variety. There were programs that were very, very standardized. I had programs that said the following question is standardized. Are you ready for it? And they would ask and then they would proceed, no comments. And it felt very, very artificial. I had other programs that weren't so much like that. But you'll get questions, like, behavioral questions and stuff like that, which are part of the standard for the AAFP. And then, I think one of the biggest surprises for me during my FM interviews was that I was always told that they just want to get to meet you and your hobbies and stuff like that, see if you're chill. That's what I was always told. And my biggest surprise was that I got a lot of questions about the future of healthcare and the future of family medicine, and what our role was in larger expected changes in our healthcare system. And so it requires a little bit of, thinking more deeply about patient care and our current unsystematic healthcare system.
Yeah, I would say I think I had a pretty similar experience in terms of having kind of certain interviews being like much more standardized, and other interviews being way more kind of loose, I guess. I had some questions similarly kind of on the healthcare system, like, where do you think family medicine fits into all of this? I also just had some kind of out of the box questions. I had one interview that was asking why people were poor in general, which was an interesting question to get kind of out of nowhere. So I think it does like cross the gamut of like a lot of different things. One of the things that I found a little bit difficult was figuring out how they would get to know me in such a short amount of time. I don't know about the rest of the panelists, but I had like my longest interview was maybe 15 to 20 minutes for one person. And I know that like 3 to 4 people, depending on the interview. The place that I'm going now, UNC, I did an AI there. And so I had a way more better idea of like what that program was and what the day-to-day would look like. And I think they also had a better idea of like how I would function as an incoming intern. And I think that was a huge bias for me in terms of evaluating other programs in comparison to this. So it was something that I struggled a lot with, of trying to figure out like what the actual culture is like, because it's different. What they tell you may be very different from actual reality.
I think that's a really good point. I also think that like for me, I was really disillusioned with my former top choice. I did a sub-I there and then actually removed my application because I was like, I don't want to be here. And then my other sub-I, which was my top choice, which gave me a lot of indications that they wanted me, ended up not ranking me to match, and then I soaked. So I think like for those who are thinking like, oh, do I have to do an away AI? Like you totally don't. But I do think it is super beneficial because it's really hard to get a sense of the day-to-day otherwise, and also getting a sense of like what that location is like if you've never been there. So that was like very helpful for me. But as far as interview questions, they asked me a lot about like the more esoteric parts of my application, like experiences that I had in the community during medical school, my other like things that I also participated in that were like non-medical. So like the poetry that I write, my website, things like that. I also got a lot of questions like, you know, what's the hardest thing that you've been through? And like, how did you make that work? A lot of questions about like, how do you deal with conflict with other people? Because ultimately what we are in is a very relational profession, right? And we have to deal with tough people sometimes. Family medicine is kind of that last stop where it's like, when you have a difficult patient, you don't just send them to somebody else, they're yours. And so you figure out how to kind of navigate that. So I think that was a pretty big theme across many interviews, but I will say that there was certainly variety from place to place. At some places I would have short 15-minute interviews like Saloni said. At other places I would only have maybe 2 or 3 interviews that were longer, like 20 to 30 minutes. I got really bored of the interview process, to be perfectly frank, because it felt like the same thing over and over and over and over and over. And I'm curious to see how things kind of unfold this year, because that was also some data discussed at the conference I was just at, was virtual versus in person. I felt like I didn't really detect a huge difference between virtual versus in person. In some ways it was a lot easier. In some ways it was harder because I didn't have the transportation barriers or like the expense of like having to go somewhere and take that time away. But also it was kind of a disadvantage because then you don't really know what the town or the city is like. And you get a very different sense of people when you're meeting them for the first time online. I'm not sure if Christian or Saloni have anything else to say about that, but that's definitely something that the ABFM is thinking about for the match next year.
Yeah, I definitely agree. I think I interviewed at more places than I should have, frankly, because it was virtual and I didn't have, like Livia said, like any of the transportation financial barriers of like having to actually go to these places. But at the same time, I actually don't think I should have done that, and because it wasn't. I got bored at the end. Like there were places that, again, I had applied to that maybe, you know, in retrospect, hindsight, I guess, is 2020, but that I should have maybe not applied to. So I think there are definitely some things I would change given like the virtual in-person thing, but at the same time, seeing other friends kind of having all of their interviews in person, there was a part of me that was also very thankful that I didn't have to, you know, miss rotations and like have to schedule all of that. So it is a weird thing. And also like I had a couple interviews where they would literally like FaceTime everybody and like show you the clinic via FaceTime or like via a video they made, which I don't know, some part of it was good and nice because you got to see it, but at the same time, like I don't know how helpful it was in terms of determining my overall rank list.
Right. Yeah, thank you all for that. We have a couple minutes left in the scheduled time. Panelists, of course, thank you for coming here. You're free to leave at any time to handle other things. But I did want to, before I ask another question that we had received, I wanted to open up. Anyone in the meeting is certainly welcome to enter any questions they have through chat. I'm looking right now at the form we sent out, and I don't see any additional questions. So one thing I wanted to ask about is letters of recommendation, because we got a few questions about that came in. How did you choose your letter writers, and would you have done things differently if you had another go around?
I
So
love
I
you
think
guys,
you're
and I gotta
helping-
go talk to my realtor, but I'm here for you. And Joey, you have my contact info.
Thank you so much,
Hi,
Olivia.
Olivia. So I would say that for me, well, for everybody, it's going to be very specific. But in my case, I did the Metro LIC rotation, clerkships. So I thought that I made a lot of connections during my third year that sometimes were even more significant than my fourth year in my AI. So I had a lot of writers for my third year and some for my fourth year. And then some internal medicine writers because I actually dual applied into internal medicine primary care track programs and then FM programs. So you just have to find a mix that works for you. And in my case, I felt like my people could really speak to what I could bring based on my third year experiences.
Yeah, I think for me it was people who could really like again, people who know you the best, who can speak best to your abilities and your future abilities as an incoming intern. For me, I had one person who was my longitudinal preceptor for my first 2 years, who was family medicine, pretty much the reason I ended up in family medicine. I had one who was a primary care doctor I worked with during my third and fourth years. One of them was one from my AI, and then one of them was since I'm in the learner program, we did an extra year of research because my research was like socially and like public health related. I wanted to make sure to kind of showcase that because I think it fit well with like the story I was telling and about why I wanted to do family medicine. So I think all of them really complemented each other. At least hopefully, I haven't read any of them, so I don't actually know. But I'm hoping my goal was that they all kind of complemented each other and my application in a way that really showcased a whole story of what I was and who I was and what I stood for. I don't know that I would really make any changes kind of looking back. I think that was I think I made the right choices in terms of people that I asked.
Yeah, thank you for that. And I want to acknowledge a question from the chat. How many programs did our panelists apply to? And do you have advice regarding that number?
So I think along with Soloni, I agree. I probably interviewed and applied to more programs than I should have. I interviewed at well, I applied to around 20 programs and I interviewed at 16. And I withdrew I withdrew from one interview so that I never completed. So I had gotten invitations for 17 and then I ended up doing 16. So, and like Saloni said, like by your like 14th or 15th interview, it's like very repetitive and it felt very, very casual and like let's just get this over with. But having said that, when you're making that schedule, I wasn't expecting to be as tired as I was by the end. And there were programs that I was that were still fairly high on my rank list towards the end. And so that was kind of an effort that I had to put into that. And so that can be a little taxing, you know, mentally and emotionally for you to, even when you're tired, you still have to bring that energy into the interview because it's a program that you're very interested in. So just something to keep in mind. I wouldn't recommend doing your first interview with a program that you're really, really interested in or that you want to rank to match. Because that first one will give you an idea of what it looks like to interview at programs. But then I would say I wouldn't put them at the end because then you're going to be exhausted. You want to put them somewhere in the half top, you know, of your calendar. And that I feel like that's when you're in your prime of interview season.
I agree. I also applied to way too many, and I'm gonna apologize in advance for. I realize how awful it sounds, kind of looking back, but I applied to 30, and I ended up interviewing at 22. Again, absolutely would not have done that. I would have done way less. But I think in the moment, I also didn't have any other friends applying to family medicine, so I really had no basis for what to do. And a lot of my classmates, they're all applying to much more competitive specialties. So I think their panic made me panic. So please reach out to us if you ever need help with like applying or figuring out where to apply, because I've definitely made a lot of mistakes in terms of the actual application process, picking schools and whatnot. I agree absolutely with Christian in terms of like where to place your like most important or most coveted interviews. Definitely put them in the middle. I would say keeping like the early ones open for schools where you would like to go, but maybe you don't know enough about the program or you want to like use them to practice your interviewing skills. I think that's totally valid. And then for me specifically, I was pretty set with UNC being my top choice. And so I think for me, I had that interview in December, early December. And so I had gone through kind of most of my interviews, and it also gave me a really good basis to look back. I had done my sub-I in September, August, September. I did my interviews, and then I was able to kind of go back to the program and like make sure that it was really what I kind of remembered it being. And I think that allowed for a good like sandwiching of programs. But yeah, that's what I would say in terms of applying. Don't apply to 30, it's too many. But if you do kind of want more specific help or advice or anything, like please feel free to.
Yeah, thank you for that. And since we're at time, I want to ask one quick question and invite the panelists, if they're comfortable and are willing to provide any feedback, if you could just put your information in the chat, your contact info, and I'll be happy to share that with our mailing list. But just as one last question, what would you say were your biggest surprises, or if nothing else, what would you say are your take-home messages for people who are considering applying FM?
I think for me, it was, I really had to keep very centered in my mind about where I wanted to live and practice and what I envision my practice to be. And I understand that that can be a very hard question to ask yourself, because if you don't know the full scope of what family medicine is, and it's kind of hard to have a fair answer to that question, you're going to have a biased answer to that question because, like someone mentioned earlier, you're going to only have an idea of what FM is through the lens of one of our hospital systems in Cleveland. But just learning as much as you can about what family medicine looks across the country. And it's going to look very different in New England area versus the Midwest versus mountain area versus the Pacific Northwest. And they're almost, they have their own subcultures and what family practice looks like in those areas. So, ask yourself, where do you want to live, or envision yourself living, and what your practice will look like. Because, like we mentioned earlier, you might be in a city where the politics of the region have determined that the role of the family medicine doctor is to be in the community and not do procedures. And then there are cities and towns that, because of the sheer need or because of the culture of medicine in that area, they've determined that family doctors can scope or they can do vasectomies. All of those different things that are available to some programs. So that would be my biggest takeaway in terms of if you're considering family practice, to consider when you're looking at programs.
I absolutely agree. I think the other thing that I would say is also like it's okay to let personal life also dictate where you go a little bit, or like at least contribute to it. For me, it was important that I was close to some sort of support system, and I know for a lot of people that is very important. And I think that was a tiebreaker for me between my first and second choice was where will I have the most ability to see family when I have my one day off. And I think one of the things that maybe as medical students, at least I remember feeling, was like you grind and you grind and you grind, you work really hard. And you don't stop to smell the roses all that much. And residency things only kind of get harder from there. And so having kind of letting your personal life, finding that work-life balance, I think just kind of thinking about it starting now is super important, because if you start to prioritize it now, it'll become easier to prioritize it when you are actually working 80-hour weeks.
All right. Thank you so much to our panelists and to Olivia, who unfortunately had to leave early. You all shared so much. I am personally going to take away, just talk to the residents, do whatever you can to make sure that you're learning about what that program can do, because there is such a diversity of experiences across hospitals, across regions of the country, across all kinds of things. So thank you both so much. Your contact info will be shared with people who were able to view the recording of the panel. And for everyone else who attended, thank you so much. I hope you have a wonderful night, and please feel free to send questions along either directly to the panelists or through me or Lydia as co-chairs of the Family Medicine Interest Group, and we'd be happy to connect you. You all take care. Have a wonderful night. Thank you all for coming.